Yeah, that's it. Thank you very much indeed. And thank you also for inviting me to talk here today about the study that we're also in the middle of, although we're halfway through, and I'm going to talk about the first part. And how it came about is that a small charity in the UK, the Burdett Trust for Nursing, put out a call last year asking for research that would help support nurses' wellbeing and resilience during COVID. I am a nurse by background, and I'm a care home researcher, although my previous research has been about hydration, but it was something that was that we felt that we wanted to contribute to and do, and that's we put in an application and we have the funding, and we've now, as I say, halfway through the study. So next slide, please. So just to put it in context, also to explain, because I'm not quite sure about other countries, but in the UK, we have two different types of care homes. We have care homes for residential care, which is staffed mainly by non-nurses. And we also have nursing homes, which are staffed, they have to have a nurse on shift for every shift, with a lot of the care being done by care staff, but always there needs to be a nurse. The ratio of nurses to residents is variable because it depends on the dependency of the residents, but very much as a result, nurses practicing in care homes can often be the only trained nurse on shift, and so they're often in leadership roles, and they're supporting their staff and the nursing residents with complex clinical needs away from an acute sector. So often in isolation without that immediate on-call or peer support that they may get in an acute ward or setting. I was also very aware as a nurse that nurses in care homes often feel undervalued amongst their peers, amongst nurses. You know, if you work as a care home and a nurse, that's not seen as the good career move, if you like. So that's the context in which we were working. And so because of that, we wanted to look very much at nursing as a distinct role within a care home. And that's not for a minute to undermine all the work, the tremendous work that's been done by care home staff, but we wanted to look at nurses particularly because of our accountability to the Nursing and Midwifery Council. As nurses, we are registered and we're accountable for our practice. And so that's why we have sort of qualified who were involved in this study, that we are interested in Nursing and Midwifery Council registered nurses to have a look and see, is there another particular dimension that we're perhaps missing if we look at the care home workforce as a whole. So our methods is in two stages. We wanted to interview nurses initially and focusing on the impact of COVID-19, and also then to explore what those findings were in workshops. So next slide, please. So as I say, we've undertaken the interviews. That was the first phase, and that's what the phase that I'm talking about today. The initial workshops and follow-up workshops literally completed last week, where we discussed with another group of care home nurses findings from the interviews, and our aim is to produce some recommendations that will come out of this that will support nurses and care home nurses particularly. So next slide, please. So throughout this, as Kathleen said about our first study that she talked about, we set that up very quickly. But this one we had a little bit more time, and we're very keen to involve advisory groups and advisory group members from the care home sector who could support us and give us that real life experience and insights into care homes. And we currently have 4 care home nurses who are part of our advisory group. And I think they're finding it a very interesting experience. They're telling us about what it's like to be an advisor on a study that's about them. So they helped us develop a topic guide. So we co-produced that. And they're also helping us throughout the findings and the analysis stage as well. So recruitment and sampling, we're very conscious we're undertaking this study in a time of extreme nurse and care home workers shortage throughout the country. And that has affected our recruitment, we feel. But having said that, we managed to recruit 18 nurses, which is absolutely fantastic. We recruited throughout England, Scotland and Wales. I'm afraid not a great response from Wales, but England and Scotland have been absolutely great. Enrich have certainly been tremendous in their support in helping us to recruit as well. And also we've made direct contact with local nursing homes, and we've also used Twitter and Facebook as well. We had a purposive sampling strategy for age, gender, ethnicity, type of care home, dementia or nurse or general nursing, and location, and also size. And as they were online interviews, because of COVID, we weren't able to do any face-to-face, and we're analysing thematically. Thank you. Next slide. So we've recruited 18 nurses, and we felt we really did reach data saturation with the 18 nurses. 16 of those were female. The majority were registered general nurses, but there were 2 mental health nurses as well, with a range of ages. Mean time registered with the NMC was 19 years, different ethnic diversity, and different care home sizes with a range of between 27 and 82 beds. And the number of care home nurses on shifts ranged from 1 to 7, with a median of 2 nurses. Thank you. Next slide. So the word cloud shows really, these are words and quotes directly from the nurses themselves throughout the interviews. And it really seemed to focus on 2 areas. There was very much the stress of being a care home nurse throughout the pandemic. But there was also some positives as well that came out. So the stress is very much related to feeling abandoned, and that was highlighted very much by a lot of our nurses about the clap for the NHS that started in the UK in March time last year. It changed after a few weeks to clap for carers, but that really highlighted their sense, the care home nurses' sense of being abandoned when it was clap for NHS. They felt maligned, they felt absolutely emotionally drained, a whole range of emotions going through from sadness and fear of catching COVID, fear of being the one to pass on COVID either to their residents or to their families. But also there were lots of positives as well. A lot has come out about the upskilling of nurses and their renewed confidence. Because the position that they were in, health professionals weren't coming into their homes. They had to take on renewed skills and upskill themselves, and became confident because of that. And also, as Kathleen said in the previous study, there is this huge sense of teamwork and working together and pulling together and pushing through and getting through this pandemic. So next slide, please. So focusing on enhancement of skills, which the nurses have told us is really rewarding, because there was an absence of health professionals visiting the home. They were very much more relied upon by their GPs and other health professionals, not only to deliver care, but actually developing skills to assess their residents and passing on that information as well. So talking, nurse number 9 here talks about being empowered. It's empowered nurses, and there's a renewed recognition of nurses' skills, positive ways. GPs now value and trust my skills. And also at dealing and looking after people at end of life. As one nurse says, we weren't brilliant at anticipating death, but now we really look at that, and it feels 100 times better, as that skill has developed with the experience that it's come with that. A couple of nurses, thank you. A couple of nurses did say that actually it also came with enhanced paperwork as well. There was a lot about balancing leadership and nursing care with their own lives. constant assimilation of information. That's coming out, today already so much. There was a bombardment of guidelines and information going into care homes, and nurses felt that not only was their job to interpret those, but if they needed to interpret them correctly and in a way that staff would still trust them and their judgment. And also the demands of reduced staffing, because people were not only leaving, but they were off sick or they were self-isolating. And as one nurse said, they couldn't get agency, and she worked from Sunday lunchtime to Wednesday morning. And, that's a tremendous amount of hours, and just having to pull through and ensure that all the nursing tasks were being done. And if anything, there was a move as well towards task-orientated nursing, doing what you had to do, as opposed to not always being able to do some of the things that, the fun things that you'd like to do as well. Thank you. Next slide. So we're interested in emotional support for nurses, because nurses are very much the leaders. So who supports the leaders? So as one said, a couple of us are mental first aiders, and we made sure that all the staff we knew that were there, that we knew, that they knew that we could talk, they could talk to them. But actually what was coming across was actually who was supporting the nurses. And who was supporting the leaders, and where was their support coming from? As the next quote says, being a manager is always a lonely occupation, because you can't have friendships in your workplace. And nurses, where they've gone to for their own support tends to be peer support with friends who are nurses, perhaps in other nursing homes or even in the acute sector as well. But also what's come out is very much needed the support from people who understood the situations that they were in and were going through. So not a lot of, although there are helplines out there, no one that we've spoke to has ever used a helpline, because it's at the end of a line that people that they don't know and can't relate to. Thank you. Next slide. Residents and relatives has been very much an up and down experience for the nurses that we've talked to. Nurses often describe themselves as being the bridge between the residents and the family, and they found what has been described to us is that relationship has changed over time. Initially, there was a lot of community support and a lot of support from residents and relatives as well, but we're now nearly 2 years into this pandemic, and there's a lot of angst, as we all know about, and which we will be hearing about as well. And the bottom quote really struck home, really. Certainly brought me to tears, just because of the abuse. I haven't seen my mum, you've done this to her, and if you kill her, and all the rest of it. So you're left with all these nasty words in your mind. So there is a feeling now that nurses are in between government policies and guidelines and relatives as well, and being on the front line, they're getting a lot of that angst as well. There are some dilemmas and differences within the accounts. Of course, not everyone's experiences are the same. Few nurses were concerned about being asked to undertake clinical work beyond their expertise. As I say, this was a positive for a lot of our nurses, but also referring back to our accountability and professionalism as nurses, we adhere to the NMC's Code of Conduct. And in that it says that as nurses, you must work within your competency, and otherwise you could open yourself to disciplinary action. So some of the nurses were concerned about that they were being asked to work and take on work beyond their expertise. Anecdotally, some of the, I think it would be an interesting exercise to look at, is there a decrease perhaps in nurses being referred to the NMC for disciplinary procedures? Because again, what people have been telling us is that there's an increasing tolerance of, because it is so pressured and there is such a lot that needs to be done. Some nurses found it difficult about making decisions on whether to enable family visiting as residents who are reaching end of life. A couple of nurses questioned whether optimum care was being offered for non-COVID related health conditions, because there was a reduction in health professional visits and a reduction in outpatients appointments as well. And also a number of nurses told us, you know, they tended to work in perhaps multiple places, either more than one care home, or they worked between care homes and the hospital. But due to COVID and being asked to focus either on one place of work or another, a lot of them lost their second employment contracts, which of course had a financial burden as well. Thank you. Next slide. So just to conclude, that nurses are often managers and clinical leaders in care homes, and they need tailored support to ensure that they may remain resilient and mentally robust, especially as they're grappling with ongoing challenges of low staffing levels, new COVID variants, and different policies on family visiting. And again, what nurses have been telling us is where there are mental health first aiders perhaps within the care home, if those mental first aiders are not their peers or more senior, again, they're reluctant to go to them, because also in the work situation, they're responsible for those workers as well. So support for nurses, you know, if we can support the nurses as leaders, we'll likely benefit other care workers. That's obviously going to trickle down and have an impact on the whole workforce, and providing an environment where the care home workforce is healthy, stable and productive. Thank you. And the next slide. To acknowledge our funders, the Burdett Trust for Nursing, who is funding this research, and also that some of us, myself and my colleague Linda, were members of the Inclusive Involvement in Research for Practice-Led Health and Social Care theme, which is part of the NIHR Applied Research Collaboration, and Christy is Deputy Theme Lead for the Mental Health Over the Life course theme. Thank you very much.
Thank you very much, Diane. And I think what we'll do is we'll move next to